Okay, good morning, everyone. I think we are ready to start. Dr. Bray is. I'm Dr. Ty. I'd like to first introduce our speaker today, Dr. Natasha Bray. She will be speaking on osteopathic recognition. Our program is underwritten by an educational grant through OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the GME office. Dr. Bray is Interim Dean of the OSU College of Osteopathic Medicine at Cherokee Nation in Tahlequah. She previously served as Associate Dean for Academic Affairs at OSUCHS at the Cherokee Nation since 2018. Dr. Bray also serves as the Associate Dean for Accreditation and is faculty at Tahlequah Medical Group Internal Medicine Program. Prior to joining OSU Center for Health Sciences, Dr. Bray served as the Associate Dean of Clinical Medicine at the AACOM in Fort Smith and the Vice President of Academic Affairs, DIO for Broward Health in Fort Lauderdale, Florida. Board certified in internal medicine and addiction medicine, Dr. Bray earned her doctorate of osteopathic medicine degree from OSUCHS and went on to Philadelphia College of Osteopathic Medicine and completed her internship as a chief intern physician, then completed her residency at Cambridge Health Alliance Harvard-affiliated hospital. Dr. Bray has extensive experience in the development, accreditation, and delivery of educational programs for both undergraduate and graduate medical education. Dr. Bray serves on several national committees and has dedicated her career to medical education as a vehicle to serve vulnerable populations and improve access to quality health care. Please welcome Dr. Natasha Bray.
Thank you so much, Dr. Ty. I wish that I was actually with you guys all in person. It's really weird to give these types of lectures without being able to see you all. But I'm excited to talk to you this morning about something that I feel really passionate about. And I've spent a lot of time and energy, hopefully supporting throughout our educational system. So we're going to talk about osteopathic recognition, and I'm going to give you a little bit of the background and overview of what it is, why it's important, and why we are where we are today. So with all of that being said, I think it's important to share disclosures. Let me get my slides where they're going to advance for you. So I am the former chair of ACGME's Osteopathic Recognition Committee. I sat on that committee starting in 2014, prior to it being a recognized ACGME committee when it was just a work group at the time that the Memorandum of Understanding establishing the single accreditation system was signed. So from October 2014 until June 30th of 2021, I sat on this committee for ACGME. So saw a lot of changes and a lot of growth over time, and we'll talk about some of those issues. I am no longer on that committee. However, I do chair ACGME's Council of Review Committee chairs, and because of that position, I sat on ACGME's Board of Directors and on their executive committee. I'm also a director for the NRMP Board of Directors. NRMP, for those of you who don't know all those acronyms, is who runs the match services. So before we start talking, I want everyone to really understand any opinions or recommendations that you hear in this talk are coming from myself. They do not constitute approval or endorsement by ACGME's Osteopathic Recognition Committee. So it's important for you to understand that this is coming from my expertise and my experience. And that means that I could be wrong. So I think that that's always kind of important to understand. So we are going to spend some time today, oops, I apologize, talking about what the background is, the who, what, where of osteopathic recognition. We're going to talk about some important requirements that I think people need to understand because it helps shape how we do education and how we quantify things. We'll talk a little bit about we are DOs. Does this matter? We graduated from an osteopathic school, so do we really need to have this system and go through the steps? And then I want to touch on a little bit, I'm a student or a resident and I have to sit through this as part of Grand Rounds. So why do I really care? and give you some reasons why you should care. So I do have a fact sheet over there. ACGME, AACOM, and AOGME have put out some information. Right now, there's approximately 2,000 plus residents who are in osteopathically recognized programs. You can see the graphs there. I'll blow these up for you a little bit as we go through. So the background on osteopathic recognition is it was really something that grew out of the single accreditation system. And as we looked at the coming together of the AOA graduate medical education programs and ACGME into a single accreditation for graduate medical education, the question was, how do we retain this osteopathic principles and concepts in the graduate medical education environment? So in our medical schools, the DO programs are accredited by COCA, so the Council of Osteopathic College Accreditations. In MD schools or allopathic schools are accredited by LCME, which is the Liaison Council for Medical Education. So they govern what is taught at the undergraduate medical school level. The question is, as we move into GME, is it important to continue to bring osteopathic principles, patient care approaches into that environment? In ACGME's leadership at the time of that memorandum of understanding in this establishment said, yes, we need to find a formalized way of making sure these things get brought into the graduate education, that they're valued, that we grow them, and that we share them, because there is a belief that it really does make a difference for patients. So when we talk about patient safety, we talk about length of stay, we talk about all the quality things, it was felt that osteopathic medicine and the approach to patient care was important to make sure that it's maintained. And you'll hear me talk a lot about the osteopathic principles and practice, more so than OMT. So more so than just manual medicine techniques, because there's a lot more that goes into being a DO than whether or not we do manipulation on a patient at every visit that we see them. So as we think about that, I want to challenge all of us to keep that in mind. What are those exact things that define us as osteopathic physicians, and how do we bring that into the environment in a structured way that allows us to measure and assess the growth of residents, the growth of our learners over time? I apologize, I have multiple screens, and at times it doesn't want to advance then when I click. So what is osteopathic recognition? And this comes straight out of the requirements. And I have a QR code on the slides a little bit later that you can scan if you want to go to those directly. But I put this up here because, again, it's important to really understand a shared language. And that was what the requirements were about, is taking people who have different philosophies, slight variations at different schools in different GME systems, and bringing them together so that they're using shared language, because that shared language is how we begin to talk about assessment over time and outcomes associated with it. So osteopathic recognition can be conferred by the committee on any ACGME graduate medical education program that's providing education related to osteopathic principles and practice. OPP refers to a philosophical and practical approach to patient management treatment, including OMT, based on the understanding of the body's unity, self-healing, self-regulatory mechanisms, and the interrelationship between structure and function. These are all the things that you got taught in medical school, but it really is important that the start of the requirements is based on this shared understanding. So OPP further defines that conceptual understanding and practical application of distinct behavioral, philosophical, and procedural aspects of clinical practice related to the tenets of osteopathic medicine. And I'm not going to read those to you. I hope that everybody's listening to this is familiar with those at this time. So the recognition committee is made up of mostly osteopathic physicians. There is an allopathic physician who sits on that, and that has been a precedent since the beginning of the committee. It includes one resident member, and it has a public member. Again, that is consistent with ACGME's committee structure across the different review committees. So the ORC drafted the first version of the osteopathic recognition requirements, and they are responsible and charged with ensuring that those requirements remain up to date. So the requirements have changed from that initial writing of them that happened in in late 2014 that went live as we went into the single accreditation system. They've been updated and evolved over time. Really important to understand, because there is a mechanism through ACGME's requirement process where the public is those of you who are program directors, who are directors of osteopathic education, who are residents within the programs, can provide feedback. This works, this doesn't work. This is too onerous. This is important. We'd like to see growth in this area. Programs also have the opportunity to innovate and be creative and share best practices as to what's working. And I think that that's one of the exciting things, and I'll share some of those with you as we go through this a little bit more. So this is who the current committee is. Eileen Hugg is the chair of the committee. She is a pediatrician. Paige is the current resident member. She is in a physical medicine and rehab program. If you look down the different committee members, we have representation from family medicine, from sports medicine, from internal medicine, from NMM. Dr. Sheridan is a surgeon. Dr. Kiefer is an OBGYN. So really a diverse group of people who are engaged in education and who are looking at how we take the osteopathic recognition requirements and we apply them across a broad specialty. And that was really one of the challenges as we developed it, is thinking about these requirements and thinking about what we're asking programs to do in such a way that allows programs, whether they're a family medicine program or a radiology program, to be able to successfully apply these standards to the training of their residents. So where are we today? I will tell you that this is probably going to change in the next 24 hours because the committee met September 17th through the 19th. They haven't published publicly the committee accreditation decisions as of about 6:30 this morning, but I suspect that that will happen today or tomorrow. So we have 254 programs with osteopathic recognition. If you look back to 2015, July 1st of 2015 was the first opportunity that programs had to apply, and those were evaluated at a September of 2015 meeting. And then the next meeting didn't happen until January of 2016. So we did have some people who were very early in that process. And I have to share with you, OSU has done a wonderful job in how they have moved their programs from the AOA accreditation system into ACGME's accreditation system, and then taken that extra step to get osteopathic recognition of their programs. So as I mentioned a moment ago, one of the challenges with osteopathic recognition from a requirement side is how we think about these requirements and apply them to a broad group of specialties. So this represents the number of programs with osteopathic recognition by specialty. And you will see that the majority of the programs are primary care programs. So you have programs like family medicine, internal medicine that have really been the leads in adopting osteopathic recognition to their program, and that's not surprising. What might surprise a lot of the people who are listening to this is our OBGYN programs have done a great job with this. Our emergency medicine programs have done a great job with this. Orthopedic surgery, dermatology, and then we actually have a large number of subspecialty who have gone through the process to get osteopathic recognition for their program, and that includes neurosurgery programs, plastic surgery programs, ENT programs. So really, we're seeing this be picked up and adopted and seen as value by a large number of specialties. So if we look at programs with osteopathic recognition by state, you can see a pattern, and I'll show you on the next slide what this is consistent with. What is in parentheses are the applications that would have been reviewed at the meeting that happened September 17th through the 19th, so ended on Sunday of this week. So it just gives you an idea of program or states that have programs that are in process. Pennsylvania leads the pack with 43 osteopathically recognized programs. Ohio is number 2 with 34, and Oklahoma and Michigan are tied at 23, but Michigan may take the lead if that program was granted initial recognition. As far as what is happening within the state of Oklahoma, we have 8 family medicine programs with osteopathic recognition, 3 emergency medicine, both of our pediatric programs, and then you can look down the list. Interventional cardiology and radiology I have in orange, and that's because we're actually the only programs in the country in those specialties that have osteopathic recognition at this time. So it's something really to be proud of, the work that we are doing here in Oklahoma and the leadership that's being shown that this can happen. We can be innovative, and when we think about the osteopathic philosophy and how we apply it not only to patient care in some of our subspecialties, but how we develop and design educational systems to support that. So when I said it kind of makes sense when we think about where the programs are, I've got 2 maps on here for you. And this data is a little bit out of date because it is after the last meeting. So it doesn't take into account those programs that had applications out there for this meeting that happened last week. But what you see in the top left side of your slide is where our colleges of osteopathic medicine are located. So that is currently where we either have an accredited COM, we have a branch campus, or an additional location. And then if you look at where the concentrations of our osteopathically recognized programs, you begin to kind of see that pattern of concentration of where our schools are. So Pennsylvania, Ohio have been traditional areas where we've had good osteopathic education. And if you look at this map, and I didn't include it in this set of slides, so I apologize, versus where AOA accredited programs were located prior to the start of the single accreditation system, so going back to 2014, you will see a very similar pattern of distribution. One of the things that we have not really seen translated is we do have some areas that have not been as aggressive in applying for osteopathic recognition. Florida is one. There's only 3 osteopathically recognized programs that are in Florida. And the AOA did have a large number of residency programs in that prior to 2014. So again, this is an ongoing process. And there's a lot of theories behind why have we seen a delay in uptake of osteopathic recognition? And that's a whole conversation that we can have offline if you're interested in it. I think one of the things is we put a lot of burden on our residency program directors when we ask them to convert accreditation systems. As someone who does accreditation, that is not easy. We're asking people to change language that they're using, to adapt different policies. So there was a lot of work that went into this process to move programs. And it wasn't concentrated work. It spread out over a period of time, impacted a large number of institutions, of program directors, of program staff, and faculty who are working to make this successful. And the thought is that once they got through that accreditation process, that there was application fatigue. And so doing one more step was something that they just weren't quite ready for. And that's why we continue to see this ongoing growth over time, is to account for that. So a few requirements that I think it's important. As I said, I put a QR code on here. You can scan it. It will take you directly to the website. There were updates of the recognition requirements that went into effect July 1st, 2021. Most of them were to align to the common program requirement updates that happened. Really important, though, for those of you who do have osteopathic recognition in your program, the FAQs were also updated. And there were some very specific examples that were put in there to really help try to support programs with some areas where the recognition committee was seeing some consistent struggling. So they wanted to put some information out there to support programs. So one of the things, if you look at the track changes where you will really see a difference, is the role of the Director of Osteopathic Education. The DOE responsibilities really need to include administrative and maintenance of the educational environment that results in the education of residents in OPP and the AACOM competencies. They need to be engaged in development of OPP curriculum, in evaluation systems, and they need to teach at the designated, or they need to teach the designated osteopathic residents the application of OPP. And this is really where there was a little bit of a shift. The decision of the programs to get osteopathic recognition really carries a responsibility to provide leadership to make the curriculum successful. And the leader who's responsible for that in creating that learning environment really needs to be engaged with the residents to make sure that those accreditation requirements are being met. What we had begun to see as a committee prior to me stepping off the committee was a lot of people really actively engaged in wanting to do this, but they were their directors of osteopathic education were taking on more of an administrative role rather than a teaching role. And the committee really felt that it was important for the DOE to actually be engaged with the residents in a patient care environment. And that didn't necessarily mean that they had to be the same specialty as the residents, because they could be coming into that environment as a consultant in supporting how, if, for example, a general surgeon may be able to take care of a postoperative patient using osteopathic techniques, but they needed to have that interaction where they were really engaged in the teaching and support of that. So it is a little bit of a shift. The other kind of big thing when you look at the requirements is it actually was important to align the requirements because a lot of these tasks were pulled to other parts of the requirements. They weren't in one location. It became confusing and hard for people to follow and read. So we wanted to just align those things in a more meaningful way. So the other thing that's really important where there have been lots of questions over the years is osteopathic site directors. And these are the faculty members that are at a participating site that's most likely not your primary educational site, who really are responsible for the clinical learning environment. So questions that get raised a lot, and there's an FAQ that speaks directly to this, is if there's not osteopathic education, we're not evaluating a resident on osteopathic competencies or outcomes on a particular rotation. Maybe our orthopedic surgery residents go to a children's hospital 4 states away for a specific experience that they can't get at our medical center. Do they need to be evaluated on that experience from an osteopathic standpoint? No, they don't have to be evaluated on every rotation and every learning experience. And if we're not evaluating the residents during that learning experience, you don't need an osteopathic site director at that site. But if it is a environment or a rotation where we expect them to apply osteopathic patient care, we want to provide them feedback and we want to evaluate them, you need someone at that distant site or that location who's identified as the site director who can be responsible for that clinical learning environment. So again, just trying to provide that someone is in charge in that they are responsible for creating an appropriate learning environment for our learners. So again, this just is another way of looking at that. When do you need an osteopathic site director? You need it on rotations where you say that osteopathic education experience is occurring in that clinical setting. So really, really important. How you designate this is on your block diagram. For those of you who are program directors or program coordinators, if you need help or have questions about this, feel free to reach out to me at any time and we can talk through your specific situations, and I'm happy to help you with that. So osteopathic learning environment is another really big thing. And again, I talked about in the beginning that a lot of what happened with these osteopathic recognition requirements was a shared language, was establishing a shared language across the GME community as to what does it mean. What did it mean to be an AOA residency program? What does it mean today to be a osteopathic residency program within this AACOM accreditation system? And a lot of what it came down to is that learning environment. How are we creating an environment that fosters these philosophical approaches to patient care that supports the application of osteopathic manual therapy as an adjunct, as a supplement, as part of our patient care plans? So programs really need to create that learning environment that integrates and promotes OPP throughout the duration of the educational experience. And what we're talking about when we talk about this is it shouldn't be in this one situation, in this one environment, we're going to do OMT. It needs to be part of the thought process. And it doesn't mean that the radiology resident necessarily has to do OMT on every patient that they encounter, but more if you are in doing a procedure and you see a patient that may benefit from OMT, how do you incorporate that into the patient care plan? How do you make suggestions that they may benefit from appropriate referral for follow-up, that may improve their outcomes? So it's how we begin to think about that in a broader way, and we use each other as resources like we would for every other medical diagnosis or every other approach to care to support the overall well-being of the patient and improve their outcomes. So learning environment, lots of questions on this. There's lots of FAQs, and it's really about supporting that integration into the education in both a didactic and a clinical setting. We want to make sure that resources are provided for scholarly activity. We want to make sure that resources are provided to support didactic learning, as well as supporting clinical integration and clinical support. One of the things that's really important is programs have lots of different resources and they have different missions. So it's important to take those into account as you're evaluating an educational learning environment, in that are the resources that are being provided supporting what that overall mission of the program is? And is that mission of the program being conveyed appropriately to applicants to the program so that they can make decisions about, is this the right environment? Is it going to equip me with the knowledge, skills, behaviors that I hope to have and I hope to learn to be able to apply to whatever my future patient care goals are? And so it's that transparency of sharing information, of supporting learning, supporting patient care in a meaningful way. So some examples of osteopathic learning environments and what that may look like. It may be focused rotations. It may be a rotation with Dr. Tai, for example, where the application of OMT and OPP is utilized for most patient encounters in an inpatient or outpatient environment. And it may be with an NMM board certified individual, or it may be with an orthopedic surgeon who integrates OPP into their patient encounters, and that's part of their patient care and approach to care. Integrated rotations is where it's integrated into patient encounters. So that would be more that orthopedic surgery example I gave you. Osteopathic rounds is another great approach. So you have someone like Dr. Tai or Dr. Dyer, or who is an NMM board certified person who comes in rounds on patients and acts more in a consulting role with the learners that are there to think about how can we apply OMT, usually to an inpatient setting, to help foster the care of those patients. Clinic rotations are other great examples. It can be OMM or OMM, OPP, OMT can be integrated into clinic. It can be embedded within each session, or you can set aside specific days to refer those patients back to provide that care. And then osteopathic patient care conferences are very similar to grand rounds or to morbidity and mortality or to tumor boards. But the purpose of this is really a multidisciplinary patient care conference where OPP and OMT is incorporated into the care plan. So how can we think about the approach to these patients? So those are just examples to kind of think outside of what we normally think of as, well, we've got to check a box and get a specific rotation so that we make sure that we're doing the right thing. Osteopathic scholarly activity, kind of shifting gears, again, goes to support that learning environment. It's about encouraging and supporting how we integrate osteopathic philosophies into our scholarly activity. One of the things that was really important to the Osteopathic Recognition Committee from the very beginning was, as we shifted from the AOA educational in residency accreditation requirements into the AACOM system, this was one of the big differences in the accreditation requirements was the expectation on both residents as well as on faculty for scholarly output. While we felt that it was important to support osteopathic scholarly activity, we did not want to add undue burden. So the individual specialties have different scholarly activity requirements. And then if the Osteopathic Principals Committee, which is now the Osteopathic Recognition Committee, came along and said, and you have to do this extra thing, that felt like an overwhelming charge in something that would really serve as a barrier to programs and not allow them to be successful. So when we thought about this, the question really became, how do you integrate OPP into scholarly activities that the residents and faculty are already doing? So the hope is that we ensure that osteopathic faculty members are thinking about this, are conscientious of this when they're thinking about their approaches to their research projects or their scholarly activity. And the request is that osteopathic faculty members collectively produce 2 osteopathic scholarly activities annually that's averaged over a 5-year period. And I'll show you some of the examples on the next slide. The other was the resident side. So how do we support them in integrating osteopathic scholarly activity into what they have to do before graduating to the program? So lots of debates on this, lots of approaches, lots of feedback has come in related to this over the years. But this is what's currently in the FAQs of what's acceptable for an osteopathic faculty members on top. Topic presentations at national meetings, presentations of grand rounds, web conferences. Obviously, we would love to see increased production related to integration of OPP into the medical literature, book chapters, abstracts, case reports, along those lines, peer-reviewed things. I would suggest to you all, as you think about your quality improvement projects, you think about how you are going through processes, that's a great place to really look at integration of osteopathic philosophies, or is there an opportunity to look at what our referral patterns are for OMT, or how we're actually bringing patients back to the office for those types of treatments. The other thing that is on there is leadership positions in regional, state, and national meetings. The second FAQ that is on here is for the residents. So they can do anything that's in the list above, but they also can do things that are expected as part of a didactic component to residencies anyway. So they can do resident-led didactics. You can integrate OPP into a lecture. One of the things I did with my internal medicine program when I was a program director in Florida was we had an expectation, regardless of what topic you're presenting on, diabetes, heart failure, obstructive sleep apnea, low back pain, peripheral neuropathy, stroke, you need to have at least one slide that brings in osteopathic philosophies. It may be abnormal findings So these are the Chapman points. These are the tissue texture changes or the diagnostic structural exam changes that we would expect associated with whatever this is. It could be a research article that talked about whether OMM, OMT, OPP worked for that treatment, or maybe it didn't. Maybe there are studies out there that say that it's not very effective in that diagnosis, and that's okay. That's as important as positive findings to know that it didn't work in that group of patients. So we asked them to integrate that in. We asked them if there were treatments that were appropriate for that condition, maybe lymphatic treatments, to be prepared to demonstrate those, or to show a YouTube video associated with that, or to share where they could get information on a refresher of those types of techniques. And it worked really well, because it was an easy, obtainable thing that they could do that was quantifiable, and the residents didn't feel added too much to the time and the requirements that they already had. Residents can lead workshops with integration of OPP. Again, another way to kind of help, especially when we're a teaching institution and we have 3rd and 4th year students. So how do we engage in that mentoring, in that near peer and peer learning? And then journal club, that with integration of osteopathic content is another great way to get your scholarly activity for your residents. So again, what does it mean to integrate osteopathic principles and philosophy into scholarly activity? And really what the FAQ says, it should demonstrate evidence of creation and dissemination of scholarly work that promotes or integrates at least one or more of osteopathic philosophies. And you can kind of think of those in the buckets of mind, body, spirit interaction, structure, function, relationship, self-regulatory, self-healing, physiologic mechanisms, or osteopathic manipulative medicine into patient care. And although it's encouraged, osteopathic scholarly activity that includes OMT isn't required. So I think that that's one place where people struggle a little bit, is how do you, if you're not using OMT techniques, is it really osteopathic literature? And are we really integrating osteopathic philosophy? And I think that that is up to us as a community of what does it mean to be a DO? How do we quantify that? How do we integrate that into everything that we do? A few other things, and this is really for more on the side of our program directors and our DOEs, and our program coordinators. They have updated the requirements related to formative evaluation. This isn't really a major change as much as it is an attempt to provide some clarity for programs that were struggling a little bit in this. Remember, our formative evals are the evals that residents get ongoing throughout their training program. They're the end of rotation evals. They're evals based on continuity clinic or on specific educational activities. The formative evals, really important, that's clarified in these updates. It can't be exclusively a single patient encounter assessment. A lot of programs, internal medicine, pediatrics, for example, have what they refer to as mini CEXs, so mini clinical checklist type exams where we're evaluating a specific task the residents can do. It's the feeling of the committee that got conveyed through these requirements that's not formative eval. That's a wonderful tool. So we may do a checklist assessing a resident's ability to do a specific osteopathic technique on a specific diagnosis, and that's great, but that needs to be incorporated into some sort of longitudinal pattern. So if those are happening on a daily basis, and then at the end of the week, you sit down and say, okay, we've seen this kind of growth, this kind of development in your patient care, in your medical knowledge, in your application of these procedures, then now we're beginning to develop a formative evaluation system. So wonderful tool, but individual patient evaluation isn't really formative evaluation. The other thing that got clarified on here is 3 months is the maximum length of time a designated osteopathic resident should wait to get feedback, meaning we shouldn't wait an entire year and then the residents not have any formative feedback over that period of time. This aligns to the common program requirements and is really important if you're thinking about that milestones get evaluated every 6 months. The residents should be getting ongoing feedback in a timely manner that allows for them to grow and progress throughout the training program. Final evaluations is the other thing that was updated that's pretty important. And I don't want to spend a lot of time on this. The only major change that is here is instead of being called a summative evaluation, it's now referred to as a final evaluation. And again, this aligns to the common program requirements. And the language within this has been updated to align to common program requirements. I will put this up here. This is now in the FAQs. And I know I've talked to some of you about this previously. They went in and put in a specific table to really demonstrate when they talk about integration of osteopathic principles and practice into the AACOM competencies in a concise way as part of that final evaluation. They've provided an example here for programs to be able to use to really be able to understand that. So shifting gears a little bit, the question is why? And I think that this is probably the most important part of this discussion. Why do this? Why is it important? Why for you as program directors, for OSU Medical Center as a sponsoring institution, for the residents, for the students who are picking programs, why does it matter? And so the question is what's the value? And again, I put the references on here because I don't want you to think that this is only my voice. But there is value that is seen out there by different people. So some of the things that have been reported is it helps programs recruit residents that share their mission and interest in osteopathic patient care. And I think from a program standpoint, that's really important. When you're getting a large number of applicants, being able to focus on those applicants that really share your approach to care, that share your mission of the type of patients that you as a program are caring for, that are going to represent the values that you as a program hope to instill in your residents going forward, is something that really can't be understated. Osteopathic care helps reduce medical costs and improves patient outcomes and improves patient satisfaction. And that's pretty widely discussed and documented in the literature at this point. And it supports the continuation of osteopathic philosophy and its contribution to healthcare. And that's really the one that I argue towards. Is we chose to become DOs. We felt that it was important. We feel that it makes a difference in the care that we provide to our patients. So why at the point that we graduate from medical school would we stop continuing to learn and grow and add to the medical knowledge in this domain if it was something that we chose to do and we felt was important? So I put some quotes over there from some of the different program directors across the country that you all can read. I don't want to bore you with reading them, but I really do think that it gives you an idea of what's happening in the value that people see in the recognition. So it's not just the program director side. From the learner side, 70% of OMS 3 students indicate that they would like to train in an osteopathically focused program, and 25% of the medical students in the US are enrolled in osteopathic medical schools. So they're voting with their feet that they think that this is important. They think of it's of value. I love the quote at the top from an emergency medicine resident in Ohio. I love OMT. I wanted to continue using it in my practice. There's increasing literature base that supports the use of OMT in the emergency room as a non-pharmacologic treatment of cervical radiopathy and acute low back pain. So the residents are really vested in this. They want to share what they learned in school, and they want to continue to build on it. So there's interest from them in pursuing it. I think it's important to reflect on that, because I think sometimes We talk to residents who are tired, who are working extremely hard, who are in the middle of what they're experiencing in their learning process. And sometimes we lose the value that they see in some of these things because it's one more thing that's on their list that they have to continue to learn and develop about. But if you ask them as they're finishing their programs or as they're moving into the practice, it's the thing that they valued, that they appreciated, that they feel helps them take better care of their patients. So we have to be a little bit careful about how we ask the questions and when we ask the questions, if we want to have an understanding. But I think asking the questions regardless is really important because it's how we support not only our learners in creating an environment that's approachable and supportive of them developing as professionals and aligning to their careers, but it's also important as we think about patient care and we think about how we talk about the value of it, because if we don't see it as value, that's not going to translate to where we put our passions and where we really show dedication to development of those individuals. So I told you I wanted to come back to scholarly activity a little bit. I wanted to give you some specific examples because I think that this is somewhere where people really struggle. Education presentations we talked about, case presentations is another great one. And I know from a research standpoint, we can debate the value of case reports. But when we talk about integration of osteopathic patient care, a lot of times those N of 1 studies are really important because it's how we begin to build value, and those N of 1s can be combined into other research. We talked about quality improvement integration. We do have an opportunity because we are at OSU and we have such a broad breadth of expertise, both on OSU's main campus in Stillwater, but also on OSU's campus in Tulsa, to really think creatively in how do we integrate and how do we do basic science research focusing on the structure-functional relationship and the impact. If you're interested in education-based research, I know there's lots of people at the school who'll be happy to talk to you about that and support you and how you develop projects around that. And then I really encourage you all, both at the student, resident, faculty, and program levels, really engage on a national level. We are who this is about, so we need to use our voices to shape what is happening. I wanted to put some example work up there that's happening. These are 2 studies that are coming out of some of the derm programs. Jennifer Lloyd is the dermatology program director associated with these. If you want to get the references, you can scan the QR code. But we don't necessarily think about dermatology as something that osteopathic manipulative medicine would be applied to, but this group of derm residents have published multiple articles looking at and developing a systematic approach to patient care in dermatology that integrates osteopathic manipulative treatment and really looking at the outcomes associated with it. So it's a great article. They are very passionate. You can actually, if you Google this article on YouTube, you can find some recordings where the residents themselves are talking about the process and integrating it into their patient care experiences. Another great one is the development of pediatric osteopathic recognition track. This is more on the education side, and it really looks at how did they integrate, how do they impact skills and mindset of professional identity within the residents that were coming into this program. So just another example that is out there. From OSU side, you do have lots of library resources associated with this. If you go to the medical library at OSU, you can go to library guides and you can actually find one related to osteopathic manipulative medicine. There's all kinds of textbooks out there. So if you're thinking about having the residents integrate OPP, OMT into their lectures that they're giving as part of your didactic program, these are all resources that they can go and quickly access and be able to use to be able to share that information. Other things that are on there, there are lots of research resources that are there, whether it's citation databases or it's scholarship and writing support. So REDCap is a really useful web application for building and managing research surveys. EndNote is on there. Jane, if you're not familiar with that, helps you figure out what the right journal is to publish an article in. So there's lots of things there that can support the residents as they work through this, as well as the faculty. The library is a wonderful resource. They're going to help you with literature searches. They're going to help support you as you begin to think about ways that are ways that you can integrate and support this. We also have a full office of research that again can help as you start thinking through these types of things. I think the thing that I would tell you when it comes to doing research or scholarly activity is don't get intimidated. If you have an idea, there's lots of people within the system that can help you. And that may not even just be within your individual program. Sometimes that means reaching out outside of the program and looking for collaboration in different ways. Other things that are there, and again, I like resources, so I think it's important to share those. There are poster templates there. There are all kinds of logos. Both the Cherokee Nation campus as well as the Tulsa campus have a poster printer. So you're able to print things to be able to use if you're going to go somewhere and present. The other kind of thing that I put in here is where can I present? It's sometimes helpful to know where you can target. So the Journal of Osteopathic Medicine is the former JAOA. They are always looking for work in this domain. We are very fortunate at OSU that we have Oklahoma State Medical Proceedings, which was developed to support residents in their scholarly work in the programs. International Journal of Osteopathic Medicine is another one, Osteopathic Family Physicians. The Pediatrics has an e-journal. There are just lots of lists that are out there. Poster presentations, Research Week is there. OOA does a resident poster competition. ACGME Annual Education Conference. Their call for abstracts is open till September 30th. And they are increasingly looking for work that comes from residents. So historically, they've wanted work from program faculty and program leadership. They are increasingly looking to integrate residents into that process. They really are, they want to accept. The other area that they really are growing that I think is important for our programs here is they've just launched their rural initiatives, looking at how do we get training into rural environments? How can we talk about what is happening in those rural training environments? The reason I bring that up is that's kind of what we do in Oklahoma. That's our areas. How do we think about training residents? And whether you're in a program that's based out of the medical center there in Tulsa, a lot of our residency programs have residents that go out into those smaller community hospitals and have the opportunity to learn within those environments. So raising that voice as examples is really important on a national level because people are looking at how do we begin to think about training differently. And that's something that we do very well. AOA has research abstracts and competition, AACOM, AOGME, all of your specialty societies do. This is not an exhaustive list. I put it here primarily just to get you thinking about that there are opportunities and you don't have to feel overwhelmed. I don't know what I just did. I apologize. Okay, so resources that are out there to support you. I talked about ACGME resources. The requirements in FAQs are always a great place to start. Milestones is the other thing that's really important to kind of understand if you're thinking about how do we assess, what are our targets, how do we want to develop over time. Looking at the milestones can be very helpful for that. And there's FAQs associated with that. There's recordings that are on there associated with the milestones. Other resources that are out there relate to doing your updates. What does the faculty roster look like? These are the nuts and bolts things that the program directors, DOEs, Dr. Slick, and your program coordinators all have to kind of deal with. Agenda closing, for those of you who are listening to this who haven't gotten osteopathic recognition, the next agenda closing date is October 10th. So coming up pretty quickly, and those would go to the January meeting. The next one is January 9th, and that would go to the April meeting. So I always like people to kind of know what's on the horizon and when the committee is meeting. Tiffany Moss is the executive director for osteopathic accreditation at ACGME. She is outstanding. I know in the AOA world, we tend to call each other and not call the accreditors to ask for help, but I would encourage you, if you have questions, she can speak on behalf of the committee and really give you specific guidance as to what the committee is thinking, where their thought process is, what is happening from a day-to-day space, and where those thoughts are going. Other resources that are out there, JAOA has a OPP OMM YouTube channel. So if you want to refresh your skills and you don't have easy access to Dr. Tai or any of our other wonderful OMM faculty members, there are lots of videos that are out there that can support you that go step by step through how you evaluate and treat the residents. Other resources that are out there, AACOM, AOGME has lots and lots and lots of things that are out there. All kinds of webinars, all kinds of suggested assessment forms and things that you can think about. ACOFP also has a resource page. I did put a caution up here, and I think it's important, regardless of what resource you're looking at, if it's not on the ACGME website, realize that this is coming from best practices that individual programs are sharing, and you need to look at how old that information is, because as the program requirements get updated, these resources may no longer align to what the new program requirements say. So they're wonderful resources. They're great to help support you in your thought process, but make sure that they actually comply with the current version of the requirements that are out there, and don't set yourself up for anything. So with that, I know I did not allow a lot of time for questions, and I apologize for that. I will put up here my contact information. Feel free to email me if there's anything that I can do to support any of you in this journey. If you think that this is a terrible idea and we shouldn't waste our time on it, I would love to hear that too, because I think it's important that we continue to engage in this conversation and we continue to define what it means to us to practice osteopathically in our different patient care environments. So thank you so much for allowing me to join you today and talk about this. And I can stay for questions too, but I don't want to hold anybody else that needs to go.